Okay, greetings from Chatham House in London, and welcome to our members event that today is going to be discussing COVID-19 and palliative care, a topic that we feel has been much neglected in the current COVID-19 pandemic. But over the next hour, we're going to be discussing the importance of palliative care and really how important it is to improve access to palliative care coming out of the COVID-19 crisis. We have a very distinguished panel with us today over 3 continents who I'll be introducing in a little moment. We'll be asking you to submit questions to our panelists using the Q&A function. You should have at the bottom of your screen an opportunity to ask questions in Q&A, and questions will be collated and put to me, which I'll then put to our panelists. We're actually very honoured and delighted to be co-hosting our Chatham House members event today with the Worldwide Hospice Palliative Care Alliance. We have as our co-chair, Claire Morris, who I'll introduce in a little moment. But as I mentioned, that we have a very, very distinguished panel with us today, who I'll very briefly introduce. And if you go to the website, that you'll be able to see their more detailed biographies. First of all, we have Lucy Watts, who is a prominent award-winning patient advocate, disability activist, and is actually a user of palliative care services and has founded a very impressive group called Palliative Care Voices. And I very strongly recommend that you visit their website, palliativecarevoices.org, to see their activities. We have Marie Charlotte Brousseau, who is an advisor at the World Health Organization in the Department of Integrated Health Services, and is a specialist in the field of public health ethics. We also have from Bangladesh, Dr. Fazana Khan, who is a specialist in palliative care medicine and pain research in Bangladesh. And she has been very active in a project working with palliative care services for children in the slums of Dhaka in Bangladesh. And finally, our third continent, we have with us Dr. Zipporah Ali, who is a palliative care doctor and works as the executive director of the Kenya Hospices and Palliative Care Association, and is a great activist for palliative care worldwide. So that's our panel, and each of them will be speaking to you for a few moments after we've finished. But first of all, if I can hand over to Claire, our co-host, who is going to introduce a video for us.
Thanks, Rob. So palliative care grew from the UK modern hospice movement in the 1960s, and it's a holistic care that looks at the physical, psychological, social and spiritual needs of people living with life-limiting, life-threatening and serious illness. And COVID-19 is really highlighting the critical importance of palliative care to alleviate suffering, particularly in relation to symptom management, such as severe breathlessness, the importance of good communication skills when having difficult conversations, end-of-life care and grief and bereavement support. And sadly, however, we know from pre-COVID data that approximately 86% of people worldwide don't get the palliative care that they need. So this short video is a palliative care nurse, Laura, who is providing palliative care to people with COVID in the north of England. And in this 3-minute story, she talks about caring for and being with an older man with dementia and COVID. And the video really demonstrates some aspects of the essence of palliative care and some of the challenges that palliative care providers are facing in providing palliative care, both in the UK and globally. Just to note that the name of the daughter is a pseudonym, and to thank Laura for allowing us to share this story. Thanks.
Hello, my name's Laura and I'm a nurse. I've been working in the community as part of the response to the coronavirus epidemic, and I want to share a story about a gentleman who I spent yesterday afternoon with, who was a resident in a care home where he'd lived for 8 years. He had dementia and unfortunately had caught coronavirus and was dying. And because of the restrictions on visiting, his daughter Emily wasn't able to visit him, to be with him at the end of his life, and I phoned her and talked to her about him and how he was, and explained that I would be sitting with him, and asked if she wanted to have a conversation with him. Reassured her that he could hear her, and I put the phone on loudspeaker on the pillow by his ear, and she talked to him. She told him that she loved him. She shared how she was looking at photographs and that she was so sorry that she couldn't be with him, and that she loved him and would love him forever. And she said goodbye and said, "You can go to sleep now, Dad." And I was watching. I was crying. I was imagining myself in her position, having what I would know to be the last conversation ever with my dad, and trying to work out what I would say, and how strange and unusual it is to just not be able to hold the hand of the person that you love while they die, and not be able to say goodbye. And I was crying for all of those reasons, and I didn't know whether it was okay for her to see me crying, and there was already a kind of barrier in the way. I had like a face mask on and protective equipment, and it already felt like she had only met half of my face, and so she could tell I was crying, but she couldn't see any other part of me. And it was really profound. I realised that I didn't need to stop crying. It was just a really important thing that I was there in person and she was there in voice, and that the three of us were kind of connected. And although deeply, deeply sad, it was also really beautiful and a privilege to be by the side of somebody that's dying. And I wished I could have met her in real life and talked to her about what it was like sitting with him. And I wish I could have known what he'd been like the week before when he was still well. You only get one chance to make death as good as it can be.
Thank you very much, Claire, and a really truly moving video there, and I think very prophetic statement at the end. You can only make death, as well as can be or something. You only get one chance. And I think this is so important, and sort of thinking about families all over the world in this situation at the moment. But of course, this happening before the COVID-19 crisis as well. There's the ongoing need for palliative care, and only around 14% of people who need it getting it at the moment. So I think one of the indicators furthest from universal health coverage. But I think to start our panel, I mean, who better to speak to than someone who's been receiving palliative care services and through this crisis and before, and a great advocate for people receiving services. So Lucy, over to you. I mean, how's it been, through this crisis, and what lessons do you think that we're learning about the need for better palliative care?
Obviously, being a patient that has benefited from palliative care for about a decade now, far exceeded all prognoses thanks to great care, great symptom management, and had an amazing life because I've had the support around me. It's been really profound to hear stories of people who are experiencing different experiences to myself. I have good access to palliative care, I have access to universal health coverage, all my medication is still arriving on time when I need it, in the forms that I need it. I can still access the services remotely through technologies and different tools. I think about the inequality for people in low and middle income countries and how they are experiencing. If only 14% of them are experiencing palliative care in the first place, how many of those are then able to access it in a time of crisis like this? Mm-hmm. The thing to think about us with palliative care needs is that our needs have not changed during COVID. They've not stopped. They've not gone away. They still exist. And I think we've almost forgotten the needs of people like myself. For example, if I was admitted to hospital, I very much fear, not that I wouldn't get treatment necessarily for the acute issue, but my existing needs might not be met. And it's been very hard to listen to stories of people who are really struggling to access the support that they need in their community and to get their voice heard in the system. We're coping with new and challenging times. It's been, a fact-finding mission for all of us. For people like me, we were already facing mortality. We were already battling for support. We were already learning to accept deterioration, accept new normals, learn to deal with, progression as our condition changes, constantly adapting to how things are, and being terrified of acute issues such as infection. For many of us, we are isolating for long periods of our lives to avoid infection, to avoid cross-contamination of issues, and we are dependent on complex and intensive care. We've been very worried in this pandemic that our lives will be seen as less worth saving just because we have very complex needs, we have pre-existing needs, and when healthcare professionals have to make horrible judgments about who can we save and who can we not. I often have a kind of a dual perspective. I'm like, no, my life is worth living, I must be saved. But on the other side of it is, if my life was saved, would that affect other people's survival? Because I would take longer to recover, need more resources, and it's a very interesting headspace to be in. We've been very worried too, about DNA CPR, with blanket DNA CPR decisions being made. Actually, that's not happening with the communication with the patient and the family in their best interests, working together. We need those open and honest conversations right from the outset. And we need to be seen as worthy of intervention and saving our lives, because, people make judgments about our lives as being full of suffering and pain and not worth living, when for me, my life is amazing as it is, with my palliative care needs, with my life-limiting condition, and I wouldn't want to change it. And we've had to adapt during COVID to a new headspace. For 10 years, I've known my condition is going to end my life. And now I'm facing a new issue of COVID and thinking, actually, the death I've accepted for myself might be very different if I was to catch COVID. That end-of-life situation would be very, very different for me. And I'm so fortunate to live in the UK, to have access to hospice support, universal health coverage, technology, Wi-Fi. The hospice are able to call me and do video chats. I can have teleconsultations with my consultants. I can email my GP if my prescription's a bit late. I can access all these services from my home, where I am shielding and isolating. And for me, I have access to 24/7 care at home. I have a personal health budget. I employ my own nurses. I employ my own staff. But accessing PPE for them has been quite difficult. I'm hooked up to intravenous drips. I have very complex medical needs. I have a permanent line giving access into my bloodstream. I have various bags and tubes. And I have, a wheelchair that I use for mobility. But my life is worth living, and I love my life the way it is. And as I said, I'm 10 years beyond my original prognosis, and that is testament to good healthcare, but also good palliative care. I really don't believe I would have survived as long if I hadn't been able to access that palliative care and that symptom support. And I do live an amazing life as a CEO of a charity, working for other charities, founding Palliative Care Voices, doing consultancy, being a voice for other patients, and making sure that their voice gets around the decision-making table. And although I can't always, reach out to people personally in terms of I can't go and see them at the moment, that doesn't mean technology can't connect me with those people and their experiences, and for me to bring their experiences to this table. And I think about people in low and middle income countries that haven't got access to technology, to universal health coverage, to palliative care. How do we address that massive health inequality for these people that desperately need that support and are just unfortunate they live in a country that doesn't have the luxuries in the way that I have? And it isn't a luxury to have universal health coverage. It isn't a luxury to have palliative care. It's a basic need and a basic human right. And we need to make sure that, disabled, life-limited palliative care patients are not written off, and that in this COVID pandemic, we keep them at the forefront of our minds, because we are still existing, our needs are still there. The rhetoric in the media has very much been that, well, don't worry about COVID, because only the elderly and the vulnerable will die or suffer severe consequences. And actually, you're only the elderly and only the complex ill. People like me, that's our everything. We are those people. We are the ones that are fighting to survive. And it's been a very interesting headspace and a lot of discussion about palliative care patients, that they just feel that in society they're written off, even by their friends and their family. It's really hard to make sure that they say, actually, my life is worthy and it is worth living. For a lot of us, isolation and shielding comes so naturally. This is part of our everyday life. We do this all the time. And it's interesting that everyone is having a sample of our experiences, just in a minute way, for a short period of time during this pandemic. People are understanding that fear that we live with every day, that isolation, that lack of community and communication outside of your family support. being able to connect and touch other people, see other people. This is our reality day in, day out. We live with this all the time. This is not just during COVID for us, this is our entire lives. And we need to make sure that people understand as much as they can that, you know, you're only putting up with this for a short period of time, but this is our reality long term. And how can people understand if they don't listen to people with palliative care needs, they don't involve us, they don't use our experience for benefit and for good. I founded Palliative Care Voices to facilitate the involvement of patients and carers in decision-making processes, in advocacy, because we are the hidden voices, we are the hidden group. And if I can use my situation and my privileges, that aren't actually privileges, they're basic rights, to give those people a voice, then that would be a wonderful legacy for me and legacy for palliative care. And we really must embody the phrase, nothing about us without us. You know, even with all the death and dying around, you know, no one wants to talk about palliative care, and yet we are not afraid of talking about it. So why isn't everybody else? We've accepted death, we've lived with it, we've planned for it, we've welcomed it into our lives. Why aren't other people welcoming this in, looking at advanced care planning, putting their wishes down on paper, but why aren't they listening to us and using our experience? We live this life all the time. And often people describe people with palliative care needs as hard to reach. We're not hard to reach, it's just knowing how to access us, because we are hidden. It's going to the palliative care services, it's going to voluntary organisations, it's going to advocates like me who are well connected and saying, what can we do to help you? How can we work together? And we often talk about policies and practices and statistics and processes, and actually this is about people at the end of the day. We are not a statistic, we are not a number, we are not a document, we are not a name. We are a person with a life and needs and things we want to achieve in our life. We have often limited opportunities compared to non-disabled people, but that doesn't mean we can't live full lives. And I hope through my experiences I've shown that a life with a life-limiting illness can actually be a very enlightening, freeing thing. I've achieved far more since I've known I was dying than I ever achieved in the years before I knew I had a life-limiting condition. And we need to think about how we use that experience. And I was also asked for a briefing note recently with a team of lived experience experts around palliative care. And some of the things we recommended to the UN member states was that we provide patients with the information necessary to keep themselves safe and to self-care. So crucial in COVID is the ability to self-care, to self-manage, for parents and family members to take on tasks. I'm very fortunate. My mum is an amazing person. She doesn't like being a nurse, but she would do IVs and drips and stoma bags. She can do it all. And she's been plugging the holes in my care package that I've had to reduce due to COVID. And I'm now starting to have my care package back again. But even so, my mum could always step back in if there was a second, you know, really big bout of COVID. Or she could step back in and we could limit the amount of people that come in. But not everyone is as able as me and my mum. They don't always know where to access the information, how to get that support. We need to look at how we can support people to self-care, that we can actually continue to support patients where possible face-to-face, if that's necessary, or by telephone or over video link, making sure those communications, that contact is still there. My GP surgery phoned me yesterday for a welfare check, which was lovely, just to know that someone is thinking about you. And also making sure that we have PPE for our professionals when they come in, so that I can keep myself, my staff safe. I, as an employer of my own staff, have to keep my staff welfare and well-being in mind. Only raising DNA and CPR when it's right for the individual patient, that open and honest conversation from the outset and going on best interest for that patient. And if that patient can't communicate, going to the next best person, their parent, their partner, their family member. Keep this patient group, you know, palliative care patients in the forefront of our minds, because we are the hidden victims in this pandemic in many ways. And our symptoms and conditions remain through the pandemic, and if anything, are more heightened. Ensure access to medications and support patients to access these medications, including maybe financial assistance, support to access them from the pharmacy. I'm very fortunate my pharmacy deliver, and so on and so forth. But also make sure we have access to the forms that we need. Not everyone can take medications orally. I have to have them in IV or other forms, making sure we can still access those. And when we can't access those drugs, there are alternative treatment options. Ensuring that patients do receive alternative interventions. Maybe they can't have that intravenous infusion every 6 weeks in the hospital, but what else can we do to manage that need? What else can we do to support that patient to live well during and through COVID? And ensuring people with existing palliative care needs can get the support we need at home and in the hospital. Hospital wards are not a place for people like me. They don't meet our needs. I need 24-hour intensive care level care. If I go to a hospital ward, they can't provide that care. So making sure my mum can come with me and support me in that role. And I hope this provided a useful overview of some of the issues about COVID and palliative care patients. And I've gone a bit over, but we must understand that COVID is giving people a taste of our lives. Now we need to go forward with this, use the palliative care patients' voices and see what we can do together as a community.
Thank you so much, Lucy, and no worries at all about going a bit over. I mean, your views and voices on this are the most important, and you've explained very eloquently that even in the great NHS system, you know, that your care has been affected by COVID-19, and I think that you make a very important point about how we may have had just a little taste of what it's like with us being isolated in our houses, and we hope people are going to be more sympathetic now. I know you've had lots of interactions with the WHO DG, Dr. Tedros, who you very much influenced in this. So who better to talk to now than someone working with WHO and Marie Charlotte? So can you give us the view of the sort of WHO and you know how palliative care is being treated through this crisis?
Sure. Good morning or good afternoon to everybody. It's really a great opportunity for me to be in this dialogue today. And I want to thank the Chatham House and WPCA for this opportunity. We have been working over the past years in trying to ensure better access to palliative care. As Lucy was strongly saying, a minute ago, this is not the case in a number of member states. I would like to bring three main issues for our discussion around this virtual table today. The first one is the reason why we are all committed with palliative care. It's an ethical duty. It's the duty of ensuring the continuity of care, what we would call the non-abandonment duty. And this is something we cannot forget, whatever situation. In a crisis like COVID-19, well, the context brings a high risk of disruption of health services, including actually in high-income countries. And we have been saying this over the past weeks. Human resources, infrastructures, financial resources are suddenly focused on the response to the pandemic with a high risk of delay for other health interventions, in particular, but not only for non-communicable disease, and a high risk of interruption in the continuity of care. We recently, this week, actually issued a guidance on maintaining essential services. And I think this is a key message we have to learn from this crisis, because we know from the previous one about the risk of not being able to provide these essential services. It's also an issue for people working in the field, the clinical teams, because they are facing on a daily basis huge challenges by attending much more patients in hospitals, in health institutions, and we had this very strong testimony through the video opening this discussion today. I think it has been a very challenging situation for many institutions, in particular in long-term care, or people attending patients at home. And it's particularly difficult to establish priorities and make complex decisions in this kind of context. The only way to face this situation is to be prepared in advance and to analyze, as we start doing it now, experiences. For example, we worked and published a guide 2 years ago on integrating palliative care and symptom relief in response to humanitarian emergencies and crises. And that was an intent to help country and help services to be prepared for a situation like this COVID-19 crisis. Actually, this document was the basis for a more recent document, which has been updated actually last week, to be sure that palliative care is included in clinical response to this COVID-19. We also saw in the video how innovative technologies or innovative approaches can help. It's not the best solution, but telemedicine, teleconsultations, communications through digital tools have been extremely useful to maintain contact between patients and family, and also between different levels of care. This is something we also studied in detail a couple of years ago in particularly challenging contexts, and actually we tested a simple mobile application that was piloted in Uganda, in Zimbabwe, and also in India, to facilitate communication between family care provider and palliative care teams in remote and rural areas. So I think we have to be creative, and we have to invent new modalities, sometimes not so sophisticated, but new ways to really facilitate the communication between the different levels of care. This is particularly important for the most vulnerable populations. The third point I want to bring to this conversation is a reminder. We insisted since the resolution on palliative care was adopted by the World Health Assembly on the need to integrate palliative care approach at all levels of care and for all kind of diseases. And this has been actually a daily challenge for people working with COVID-19 patients, as it was and it is still for people working with patients affected with Ebola, for example. So we need to have this holistic approach and comprehension of the needs of the patient, including psychological and spiritual issues across disease groups and across age groups. This is obviously in the current COVID-19 crisis, particularly relevant to one of the most vulnerable population in this crisis, which is older adults. To do so, a key word is advanced care plan. So this should be systematic also for patients in life-threatening conditions to be prepared in advance and to participate actively with their family members to the definition of this advanced care plan, so their expectations, needs, preference are taken into account from the very beginning. And from this early stage, this plan can be updated depending on the situation of each patient. For health systems and policy makers, it's also a reminder that access to good palliative care, and as it was already mentioned, that means not only availability, but access to essential medicines for palliative care, has to be provided at all levels of care. That was a strong message in the Astana Declaration adopted a couple of years ago, in particular to have a strong entry point at primary healthcare level. So if we look back, what is the origin of this word crisis, we can understand that this crisis gives us an additional opportunity to make fair decisions, to get better prepared, and to take care of the most vulnerable with all the means we have, including creative and more innovative ones. And I would just finish this opening remarks with a word that Dr. Tedros has been repeating again and again over the past weeks. And this is the word solidarity. We cannot be prepared. We cannot respond to this kind of crisis without solidarity. And we learn from each other. We learn from our good and also bad experiences. This is what we have to do with all people involved. And this is what we are trying also to facilitate from the organization. So I'm now happy to have this dialogue with all of you. Thanks a lot.
Super, thank you very much indeed. And I think, WHO is doing sort of fantastic work, very, very much emphasizing solidarity, universal health coverage as the best solution to this crisis. And recognizing that even though it is a terrible crisis, it does provide an opportunity for a better world, which we all want to work towards. Now, I've got our next two speakers are going to give you perspectives from different continents. And first of all, I'd like to turn to Dr. Farzana Khan, who's speaking to us from Dhaka in Bangladesh, about the situation in Bangladesh. And in particular, I think you're going to bring to us some information around the humanitarian crisis, maybe in sort of the Rohingya camps, where people are very concerned about palliative care. So Dr. Khan, over to you.
Thank you, Professor Yates, and all the dignitaries present, and all who are listening to us. Actually, I work with a tiny organization, FKRF, which is providing palliative care to vulnerable areas, as you have already stated, that we provide palliative care to the slums and also in the Rohingya camps. And we happen to be the only organization in the Rohingya camps till January 1st, 2020, starting from 2017. And in January 2020, IOM decided to give us an award of starting palliative care for 10 camps and 2 government facilities. So we started, but I just want to share a personal history of FKRF. This is a really small organization, and we previously applied for the NGO Bureau registration. So we started working with IOM support from January 1st. And in the mid-January, we got a letter from NGO Bureau that they have decided not to give registration, NGO Bureau registration to FKRF. So you know that IOM, International Organization for Migration, they cannot give any organization who doesn't have NGO Bureau registration, and that is a bar from our government also. So then a magical thing happens. IOM decided to take over this palliative care work upon them, and they took all of our staff, 38 staff, and me as a health consultant of palliative care for IOM. So then we started again palliative care with real support from IOM. And at the moment, actually palliative care we are providing, and we are preparing a guideline with the help of IOM and health sector of Cox's Bazar. And as Professor Boeso was telling, that we need advanced care to incorporate in all stages of palliative care and context. And we are also incorporating advanced care in these guidelines. Although in Bangladesh, advanced care is not yet available in palliative care throughout our country. But in Rohingya camps, we are trying to incorporate in these guidelines. And patients if I may say so, that we have limited number of patients at the moment in Rohingya camps, only 29 patients from till yesterday. And all our palliative care staffs are working to support SARI ITCs of IOM, 4 in number. So all our staffs are working to those SARI ITCs. SARI means, that the abbreviation is severe acute respiratory illnesses in isolated training centers. So we are supporting that, and we are trying to get all the medicines, and maybe hopefully IOM is going to get opioid license also. So I would say that although the organizations which are small, they are not getting funding directly because of their own problems, and many other big organizations in Bangladesh, they are not yet that much interested to take palliative care into their activities. But IOM has started, and maybe within a very short period of time, it would be spread in other refugee camps in Bangladesh. This is my hope. Thank you.
Great, thank you very much, and truly inspiring. Your pioneering work, being the first ones in there, and and then other organisations picking up your idea, and I'm sure people all right across the world are very concerned about the situation in refugee camps, not only in Bangladesh. So maybe big lessons to be learned from your experiences. Now, just to remind participants that we are going to be taking questions and answers, and so you have plenty of time now to pose questions to the speakers who have already spoken, and also to our next speaker. So just put them in the Q&A. Don't put them in the chat function. You just pop them in the Q&A, and then they'll be sent through to me. So now to our third continent, and I'd like to bring in Dr. Zipporah Ali in Kenya to describe the situation there. And I've heard even this morning, Zippy, I think you sent over an article saying that a hospice is in danger of closing because of lack of funding, which is the last thing that we want at this stage in the pandemic. So what's the situation in Kenya? Please share your experiences.
Good afternoon, everyone, or good morning, wherever you are. Rob, thank you very much for inviting me on this panel. I'm glad to share with the rest of the team and those who are listening what we are doing in Kenya. And particularly, I'll be sharing about what we are doing in Kenya. First, I would like to say that COVID-19 has to involve palliative care. It is a disease that is life-threatening. It is a disease that is very serious, and also it comes and goes very fast. People don't have time even to, it's not like a cancer where you have time sometimes to do many things, but COVID is killing people very fast. So COVID really, one of the responses to COVID-19 is integrating palliative care into the care for COVID-19. We need to look at the holistic approach to this disease, the psychosocial support, the emotional, the spiritual support, but also the very distressful symptoms that the patients go through when they have COVID-19. Those are symptoms that we actually see in our patients in palliative care, specifically towards end of life, breathlessness, pain, cough, anxiety, delirium. Those are things that we deal with on a daily basis, and we should be able to help our governments respond to COVID-19 through developing guidelines with them on physical management or clinical management of the disease in terms of symptom management, but also on the psychosocial support of the disease. So that is very important. I just want to clarify that palliative care is very important, and it should be an integral part of COVID-19. Since we've had this pandemic, there have been many challenges. And for us, we did a very quick survey the fourth week of I think March. We did a survey because we could see from our member organizations, hospices and palliative care units, there are many challenges they are facing. And from this survey, we were able to identify quite a number of challenges related to the caregivers, the hospice caregivers, challenges also related to the palliative care recipients, the patients. For the hospice caregivers, they are worried because they didn't know how to deal with this disease. They didn't have enough information on COVID-19. They didn't have enough information on how they can protect themselves. And also they did not have any PPE. They were not ready for this kind of pandemic. So they were not, most of them had stopped doing home visits, were taking very few patients into the clinic because they didn't have the equipment they needed. So that was a big challenge. Then the other challenge was, of course, now they were not seeing patients face to face. So they could not really, have that, in palliative care, we actually believe in being very very close to our patients, having a face-to-face interaction, having family meetings. These were becoming very difficult for them. So apart from that, there was the challenge of sanitizers and many other things. The spaces they operate from are very small. They can't really practice social isolation. So some of the challenges are quite genuine, and also we asked them to ask the patients what their challenges were. The challenges for patients were quite many. They were afraid of the disease. They had been told COVID-19 it affects mostly people with underlying conditions, so they were scared. They had already cancer or whatever they had, and on top of it, they were going to have COVID-19, so they were scared they would die. And they were scared they would die in pain because they might not access their medications, for example, essential medicine like oral morphine. They were scared that they would die away from home without family members. We just saw a video that showed a parent dying without their child next to them. These were very genuine concerns. They were afraid that they might not be able to access radiotherapy services because they have to travel to Nairobi, where we have one public machine, and we had a curfew. There was no travel, but we were able to get the Ministry of Health to now write letters for patients to be able to travel. But even when they came to Nairobi, they were scared about where they would stay. Were they going to be exposed to COVID-19? They didn't also have any protective equipment. They were scared that they might not be able to make money because some of them are very poor. They sell vegetables on a daily basis to be able to get money to pay their transport, rent, and just the day-to-day living things. So the economical fears were there, the fear of getting the disease, the fear of the fact that their cancer would be neglected and all resources would go to COVID-19. And those were very genuine fears. For some time, actually things were at a standstill. We were really concentrating most on COVID-19 and forgetting people who have got diseases that need care on a daily basis. So that was a very genuine fear as well. Access to palliative care services for people with NCDs, people with palliative care needs, HIV, AIDS, tuberculosis, and people with sickle cell also were really afraid that they might not get their medicines. So this was also one of the things we were able to get out of the survey. And of course, the other fear, which we have just talked about, was the fear that there would be no money to continue providing services. A lot of our hospices depend on the public. We have a program that's called Friends of a Certain Hospice, and they give money. They do donations and they bring food for patients. Now, because of COVID-19, people are going through all economic situations that are difficult for everybody. They are not able to support the hospices. So they're afraid that they will probably not be able to continue because they don't have the donors that usually support them. And for us who are a national organization, we're also afraid because our donors were already cutting down on support since they were also going through they're also going through the same thing. So those are also some of the things we had in terms of funding. And then also the other thing that we also were afraid of is those who provide services at the community level, that is community health workers, not really workers, but community health volunteers, because they are not paid, would not be able to go and see patients they have been seeing simply because they are afraid they will get the disease, or they're afraid they'll spread the disease to the patient, to their patients. And also they didn't have the things they needed to go and supply for patients, for example, home kits that might have simple pain medications, wound dressing material. So that also was another challenge. And the other challenge, of course, again, the biggest challenge is that healthcare providers have not been trained in palliative care, really. The integration of palliative care into the medical and nursing school is a recent thing in this country. So not everybody has any background on palliative care training. So again, that is another challenge where we decided we need to do mass critical training for healthcare workers on the basic principles of palliative care to be able to provide them to the COVID-19 patients. So these challenges started us thinking, and we decided what can we do to support the government. We wrote a letter to the Director General in the Ministry of Health and told them we would like palliative care healthcare workers to be part of the team that's taking care of patients with COVID-19 as we take care of our own regular patients. And we identified the things we could help with. What that was symptom management guidelines, and we could also help with psychosocial support. And we didn't tell them we're going to help them with PPEs because then the government would relax, but we were able to reach out to some donors and say, please help us buy PPEs to be able to give our palliative care service providers so that they can go out and see patients, or they can even distribute some of these masks for patients so that the patients feels a bit at lower risk when they're coming for radiotherapy or chemotherapy. So luckily we have the Ministry of Health took our suggestions very positively and introduced us into the subcommittees for COVID-19. There's a subcommittee on mental health psychosocial support, and we have worked with them. And last 2 weeks ago, we actually trained 45 palliative care nurses and clinicians on how to support people with COVID-19, families, patients, pre, and during, and post-COVID. support. And we're now looking even at coming up with a rehabilitation guidelines and bereavement support at at a national level. So the other thing we also did with the Ministry of Health was to ensure that we are also part of the team that's developing guidelines, clinical guidelines management for the COVID-19. And we also have a subcommittee on NCDs, non-communicable diseases, COVID-19. We are also working with that committee to ensure that people who have underlying conditions continue accessing their medication. It's not 100% correct or not happening at the level of 100%, but these were measures that needed to be taken immediately to be able to respond to the need of the COVID-19 patients and the patients who have underlying conditions that will not go away because there's a COVID pandemic, but might even become worse. So we have been able to get support from our donors, and I want to really appreciate some of our donors. Actually, all of them have been very supportive, because we asked them if we could direct our funding to now respond to COVID-19, which is the most immediate thing. But of course, not neglect the work that we do, but bring COVID-19 into everything that we do. And they have been able to tell us, you can go ahead. We got one funder who gave us quite a good sum of money to buy PPE. So our office right now is full of boxes of PPE. If we were to go back to work from the office, we probably wouldn't fit in the office, because everywhere you're stepping is PPE. So we have been distributing this, and I think we have enough supply to distribute to 70 institutions who are our member organizations. That is hospices, public, mission hospitals, and some private hospitals. We have enough supply for the next 6 to 8 months for them to be able to continue to see their patients. So this is really just to help patients to be able to access services, because the people who are giving these services want to feel that they're safe, and they also want to know that they're going to be, that they're keeping their patients safe. So there are many challenges, because we depend on a lot of donor support to do what we do. Even the government, when it supports a hospice, they usually will support maybe the salary of 1 or 2 nurses, but will not support all the cost of a hospice. So the hospice, the video that I shared with you this morning is showing one of the hospices saying we might be closing down soon because they don't have the regular support. The government actually has been good in that they actually support the hospices and palliative care providers with morphine in this country. We do have stockouts sometimes, but even now we've just been having a conversation when you're going to be, we produce the morphine ourselves, we get the powder, the government brings in the powder, we take it to the national hospital, and it's manufactured there and then bottled and sent to the peripherals. So that is the other thing that we are working on to ensure that people have access to pain medication. And I want to also acknowledge our government, because just recently we got a letter from the Ministry of Health saying that morphine is going to be one of the drugs that is going to be supported under universal health coverage, that a patient should access that medicine at no cost at all. This is just 2 weeks ago when we got this letter, and we had a meeting on it yesterday with the chief pharmacist for 1.5 hours. We had a meeting on how the logistics of how this is going to happen. So we do have challenges, but also we are trying to see, as an association, how can we support the government, whether it's technical support or any like the PPE support also, but we also need support from others to help us support, the whole movement. So yes, our numbers are going up. We don't know how the curve will go. Our numbers are going up. We've run out of test kits. We had some 3-4 months to prepare before other countries, but I don't know if it goes up. I'm not sure that we'll be able to handle it. Thank you.
Thank you very much indeed, Sippy. And that's really great news. I wasn't aware that morphine has been now incorporated into the UHC benefit package in Kenya. That's a tremendous achievement, and it's absolutely vital that other countries follow that model. So congratulations to you. And this brings us on to the topic of medicines and access to medicines. And I believe that we have in our audience one of the great pioneers of extending access to medicines, particularly in sub-Saharan Africa, and that's Dr. Yusuf Hamid from Cipla Pharmaceuticals. And I was just wondering, Frini, if you could maybe bring Dr. Hamid in to be as a respondent, and sort of perhaps give us the private sector's viewpoint on palliative care. And I believe that Dr. Hamid is a big supporter of the hospice movement around the world. So, Frini, is it possible to bring Dr. Hamid in?
Rob, yes, absolutely. Let me just find Dr. Hamid.
Well, I'll go very, very quickly. The barriers to delivery of palliative care in India, we run a very large palliative care hospice in India. And these are the barriers because of COVID. Number one, the sudden lockdown. Number two, I'm not going into details. Number two, public transportation. Mm-hmm. During the lockdown period, has been very acute. Number 3, the regular outpatient services have been temporarily suspended in all hospitals. Number 4, we found that teamwork is very important part of palliative care during the COVID period. This is the access to health professionals. We are finding that inexperienced care has increased a lot because there are no professional medical care available. Yeah. Then traveling has been a big problem. Big problem during the lockdown period. Number 4, people on video calls are not appreciating. Don't forget, we're a very poor country. So the video calls are not really benefiting. Then we are finding also that with increased anxiety and mental stress, this has had an impact during this COVID period. Now, what have we done in our experience to combat this? What we have done, we've increased substantially home care services. That's something that I would recommend to my colleagues in this area. Mm-hmm. Number 2, we have created separate medical and care teams to in the hospice to care for the patients. That is, they go in shifts, they don't meet each other, and they're isolated with each other. Then what else we have done? We have separated patients in our hospice and palliative care unit according to their specific needs. This is something else I would like to recommend to my colleagues here. The other thing I would like to do, tell you that we've extended our call services. People who require palliative care, we've got a hotline, they can phone us and we can meet them. Now, why this is important is that the general hospitals in India, particularly in the big cities where there's a lot of COVID-19, they are at a standstill. And we therefore want to provide a call service. So this is what we are doing. Staff is also anxious. And overall, we are finding that families and patients have benefited from home visits. This is something I would very forcefully recommend. Now, what we would like from you is what else can we do? Pardon, what else can we do? Anything more we can do? And that's why I've attended this webinar to learn from you what else we can do. Thank you.
Well, excellent. Thank you very much indeed, Yusuf. And you're leading us beautifully into the questions, really, because I think some of the issues that you've brought up are sort of coming up in our questions. And I'm seeing a theme through this, the issue of, during the pandemic, the problems in accessing services. I mean, Lucy mentioned, that here in the UK, she is able to access most of her services coming to her house, and she can access services relatively well. But where you have these very tough lockdowns, like we've seen in South Asia, like we're seeing in Sub-Saharan Africa, accessing services is really, really difficult. So I'm just wondering for the panel in general, really, and this has come up in a sort of couple of the questions. I know that a couple of people have asked this about the balance between hospice services, like say inpatient hospice services and community-based services. Do you think that, this is something that the palliative care movement need to be thinking of more, that perhaps now more than ever, the focus should be more on community-based services rather necessarily than fixed hospice services? So, Lucy, can I come to you maybe first on that? Because, I can imagine that you're accessing both types of services at the moment. So what your views might be on that?
I think there's definitely a place always for hospice services, for inpatient hospice care. But I think there needs to be a big shift, because a lot of patients like me want to live in our homes. Mm-hmm. We want to receive support at a time that meets our needs. you know, that we can access other services, still live our lives. And I think we need to strike the balance right where we're not either or, but we have offerings of both. So the people that need that inpatient hospice-based care can access that, but also patients like myself that prefer the community-based support can access that also. You know, the hospice that support me, a young adult hospice, are a community service. So I've always received outpatient community service, but I also used to receive respite at an inpatient hospice. And that was right at that time. But obviously now that support is more in the community, and having my own home care team as well, that allows the hospice to work with my team to meet my needs best.
And Zippy, what do you think in the Kenyan context? Because I know you have sort of mixed systems there of community-based and more sort of hospice-based services.
Our hospices are not inpatient facilities except for two. Most of them are outpatient facilities. They see patients as outpatient. Patients can come in. Family members can come to collect their drugs. They have a daycare once a week where the family members, patients, and volunteers interact, and it's really like a social kind of interaction as patients are being reviewed. They do home visits, and most of the hospices work with some community health workers. And we've actually invested in training of community health workers over these years. And so community health workers work alongside the hospice caregivers and are able to reach the patients faster than the hospice, because hospices, some of them don't even have vehicles to go and do home visits. And sometimes the roads are terrible, and with the rain, you can't really get to a patient. So they work with the community health workers. And so one of the things we actually have been talking about since last week is we need to have home-based care kits. We used to have home-based care kits in 1990, early 2000s for HIV/AIDS. The Ministry of Health had home-based care kits that had simple things like anti-diarrhea medicines, pain medication, brufen, wound dressing material. And so we need to now go back to what we were doing some years back to reach the patients, because we have very few health workers in this country. Even the palliative care workers are not as many as the number of patients we have. So we need to be innovative and start going to things that worked before. Let us see what we did in HIV. We had those kits that were available to the community health worker to go home. But of course, the community health worker is doing this as a volunteer. They're not really workers, they're volunteers. And they also are not really very they're not very well off economically. So we also have to think how we can support these community health workers to be able to see patients. And just talking about Dr. Yusuf, one of the challenges that he talked about was being able to reach to patients through mobile phones and the rest. One of the things we are doing just for now, this is not sustainable. I know you'll say it's not sustainable, but it's something we see as a need, is we are supporting the hospices with airtime from a donor that gave us money. We are supporting them with airtime and smartphones, because every home in this country has a phone. That is the truth. Our phones are used to transact money. And because of that, even my grandmother in the village would have a phone because she wants to get some money from me. So we can transact money over the phone very easily. And so everybody has a phone in the house. It might not be a smartphone, but like Dr. Hamid said, we also have an SM platform where patients can send a message. And then the message comes to us and we're able to get them to the nearest health provider to support them. So I think we need to be very innovative. We are actually supplying about 20 smartphones to the hospices, so that if there's a need, they can also do a video call. You can ask somebody to show you the wound a patient has, and they can also show you their medications with a video call. So we really have to look at what is available, how can it be innovative, but also how can we help those people who need to use those innovations to be able to access care. So I think it's just thinking it might not be sustainable now, but it's a thing that is needed right now to be done, that we have to keep communication with our patients. We have to be in touch with them. And we also have to facilitate their communication with their families if they're in hospital.
Mm-hmm. Thank you very much. And you mentioned families there, and I think that Lucy mentioned how important her family members have been through this crisis, particularly when services are constrained. That families really need to step up. I actually, for a while, ran a hospice myself in Swaziland, the Swaziland Hospice at Home, and it was all around working with families. And one of our audience members, Nicholas Meller, has asked specifically about this question, about how do we work with families, how do we get families involved in palliative care, particularly in sort of crisis times like this. So Fazana, I'm not sure, that if you have views on that, perhaps from the Bangladesh perspective.
Thank you. Yes, actually, we are also using telecommunication with our patients, and at least 3 of our patients had end-of-life care within this last 3 months. So what we did, we made a schedule, a 12-hourly call with the patient's grandson, and one of the patient's grandson and other family members also. And our palliative care team would call twice a day, and sometimes depending upon the needs of the patients, our physiotherapist or once our doctor also went there, once our nurses and our community health workers, we call them palliative care assistants. We have both Bangladeshi and Rohingyan palliative care assistants. They would go to their home and help them with all those activities. And we also used the palliative care performance scale, and we shared the condition and situation of the patient's condition with the family. And that actually the patient's family felt empowered with that, because one of our patients, we told them that the patient might have 28 days we can expect, depending on the palliative care performance scale, and the patient would die at 18th day. And the family was so happy to learn about previously, and they could do other things for their granddad and other members also. And so I think this is really helpful, and we can through this COVID-19 has taught us how to do all these things with telecommunication more intensely, and we are also trying to innovate, and almost all the Rohingya families, they have got one smartphone, but although the communication is, network communication is not that good every time. But yeah, we are also trying to do that. Thank you.
Great, thank you. I've got another question. In fact, I should say that because we've got so many questions, we are going to go a wee bit over time. This is one of the few silver linings from the COVID crisis. It's not like when we're in Chatham House and there's another event wanting to evict us out of the main conference room. So we do have a little bit more flexibility, but I know people are very busy. So I'd like to ask, it's come up in a number of questions, so I won't attribute it to one person, but around meeting spiritual needs, that sort of palliative care is a very holistic form of care, and just wondering how do you think sort of palliative care spiritual needs are sort of being met, particularly through the COVID-19 crisis, and is this posing any particular problems? I don't know, maybe Marie-Charlotte, can I bring you in on that as an expert on ethics?
Thank you. Actually, I think in this crisis, like in any other circumstances, what is often missing is the capacity and the training to answer what sometimes is described as complex needs. So sometimes people are trained, and I want to also emphasize the point already made on the need to train people at the front line. But often this training is a clinical training, and it's not always addressing the complexity of this need. So I think what is key is to have the stakeholders you need in the team. So it's probably not the same person who can have the best knowledge of opioids prescription and at the same time the best knowledge of attending spiritual needs. So by definition, a palliative care team needs to be composed of different people with different kind of background. I think what we call spiritual needs is also different depending on the culture. And this is the reason why I think it's always important to build a strategy with the people from the specific context. What we do at WHO is to try to have a sort of universal approach to problems. But obviously, a bottom-up approach is absolutely needed. So you take into consideration the local culture and what also the language, because sometimes behind the words we don't have exactly the same understanding. So I think, and this is actually related to ethical issues, it's very important whatever you build. And actually when we built, I mentioned this mobile application we developed in 3 different countries. We did it with the people in the field, and we had to adapt a lot, because with a simple tool like this, you can have a much better benefit if you build the tool with the people who are supposed to use it. And I think to address these complex needs and to put something very concrete behind the wording of psychological and social and spiritual issues, we need to develop this with the people in the field, and also be sure that we are not, sometimes I think policymakers might be afraid of this kind of issue. And people from the field can have a much better approach, because they are with the patients day and night. So it's really something to build on experiences. It depends. When we work in Latin America, it's completely different from other cultures in sub-Saharan Africa or in Asia. And we really need to build this together. So this is also I think, a strong message to the modalities of work. We can have, so we try to publish guidelines and to promote access to opioids, for example, but we also need to strengthen local partnerships. So the answer to these complex needs is really adapted to the local context.
Great. Thank you very much indeed. Now, unfortunately, we have really reached the end of our session, but I'd just like, if you don't mind, to turn over to Lucy, really, and sort of having heard these experiences around the world, and that very keen to hear your views as someone receiving palliative care services. That what's your hopes and aspirations sort of coming out of this COVID-19 crisis, for where you hope that palliative care will fit within UHC going forward?
Yes, I think palliative care, we all know how vital it is. We all know that palliative care is absolutely essential. Any health system, universal health coverage or otherwise, we need palliative care. And my hope for the future is that any work going on around UHC is inclusive of palliative care. Palliative care is a primary part of that health system, because it is so crucial, that we can widen access to these services, so more patients can access them, and that patients have a better quality of life in future. But we need to monopolise this opportunity and think, death and dying is on our agenda. Let's mobilise all our communities to come together with palliative care and get people invested and break down the myths that surround palliative care. It's not just end of life, it's holistic care for the person to live well up until death.
Brilliant, thank you. And I think that's a very good way of looking at it. We need to grasp this opportunity. I mean, I even heard in the other day that Hillary Clinton talking to Joe Biden in a meeting say, never waste a good crisis. Now is the time that we should be promoting universal health coverage reforms and making sure that they're truly universal. And that's something that we're very keen to do at Chatham House. So thank you very much indeed, everyone, for joining us today. Sorry I wasn't able to address all your questions, but please do encourage people to see the recording of this, and we hope you'll join us in future events at Chatham House in the coming weeks and months. Thank you very much indeed. Goodbye now.